So thank you for coming to hear me speak. Thank you for the invite to come and speak. I enjoy serving others, and the chance to serve you this morning is a privilege, and I look forward to that. So a colleague of mine once, we're going to come back to the odd doc thing. A colleague of mine once commented to me the thing that surprised her most about the practice of medicine is how often patients were angry with her, because she went into medicine to help people, to serve people, to make the world a better place, and how often she would find herself interacting with a patient who was angry, even though her total reason for being was to help and serve this person. And she was, in our conversation, sort of processing, how can that be? How could it be that patients are angry with me when I'm just trying to do my best and help them as much as possible? So we're going to explore that a little bit this morning. And I think part of that is that no matter where you land on ethical issues, you will find yourself saying no to patients. And some of them won't take that very well. And so I want to explore a little bit how the standards around that. So before we get to that, of course, I have to disclose that I don't have any commercial connections. Nobody is providing me with any money that might in any way bias anything I'm going to say this morning. So that is there. So objectives. So I want to explore a little bit where disputes between you and patients and colleagues and administrators and colleges come from. So why do we find ourselves disagreeing with patients and colleagues and colleges? And then if you're going to end up in those situations, which you're all going to end up in, what would be best practice, if such a thing, you can think of such a thing for that. So, and then just a little plug for rural practice. This is a park that I walked through on my way to work. So where I practice medicine is a small town. I walk down a hill, over a bridge, over a river, through a park, along the river. It takes about 10 minutes to get to work. And this is part of the path that I take. It's even more colorful right now. So that's my plug to all the learners to consider rural practice. It's very nice. So you will find that if you're disagreeing with somebody about an ought. So you're disagreeing with somebody about what ought to be done in a given situation. And as soon as somebody uses language like should or ought, you're in the realm of ethics. And if you're disagreeing with somebody about what ought to be done in a situation, the disagreement will probably arise from one of these four things or maybe all of them. It gets really interesting when 3 or 4 of these things are in play. So you might be disagreeing about the facts of a situation. You might be disagreeing you might have different beliefs about the nature of the universe, which we're going to explore a little bit. You might have different loyalties. You may be involved in different projects, part of different groups, and you might be reasoning it through differently. And certainly medical school is really good at teaching you how to acquire high quality facts. And actually most post-secondary education is pretty good at teaching you how to acquire high-quality facts and how to distinguish low-quality facts from high-quality facts, all of that sort of stuff. And a lot of post-secondary education is pretty good at teaching you reasoning skills, critical thinking skills. So most medical students I encounter, they've got the fact thing down and they got the reasoning thing down. And so generally when they're disagreeing with their peers, it's because there's a difference in beliefs and loyalties. And beliefs and loyalties is more the realm of anthropology and sociology and philosophy than it is the realm of history and science. And so let me explore that a little bit. So I want to introduce the concept of worldview, which may or may not be new to you. It's a concept that I first encountered in anthropology. And it's the concept that all of us have a certain understanding of how the universe is, what we are in our place in the universe. And most of us pick that up when we are children. And one way to encapsulate it is what are your answers to all of the big questions? The big questions being what is the universe physical, metaphysical? How did you come to be here? Not what flight did you take to get to Toronto, but why do humans exist? How did we come to be? Is there a God or several gods, and what does he or she or it or they require of us? Is there such a thing as truth? And how do we get to truth? Is there such a thing as good Is there such a thing as evil? Is there beauty? How do you define beauty? So all these are really big questions that philosophers spend a lot of time thinking about, and that actually, if you've grown up in a culture where everyone kind of thinks the same way, you may never have thought about. You've just absorbed this in a dominant culture. And then what we all do is we apply our worldview to decisions we make in life. So the philosophers, all these people come up with worldview, we absorb worldview, and then we go out in the world and we do things. A little bit the way mathematicians and physicists and chemists come up with knowledge, and then engineers go and build bridges. So engineers ask, given what the chemists and the physicists tell us, and the mathematicians tell us, how do we build bridges that don't fall down? Whereas you've all sort of taken from your worldview, is it okay to tell a lie? Or not tell a lie? Or when should I tell a lie? Right? That's a fairly concrete thing. What should I eat for breakfast? Right? There is lots of ethics which would critique all your options in the buffet lineup this morning. Right? And all of that ethics is people's understanding of the universe applied to whether one should eat meat or not, those sorts of things. And then you will be most comfortable in the world if you are able to behave according to your ethics. And if somebody forces you to behave in a manner contrary to your ethics, that will be very difficult. It's kind of soul destroying. And either your ethics change, or your behavior changes, or you jump off a bridge or develop an addiction to cope with what you're having to cope with. So now where does worldview come from, right? Before we get there, where are some of the extra things that flow out of ethics? So I often say to students that law is really just the ethics we've all agreed to, right? We've agreed as a society that you should not kill somebody who would rather live. That's an ethical statement. You ought not to kill somebody who would rather live, and that's actually law pretty much everywhere. There is no place on the planet where it's considered acceptable to kill a member of your own tribe who'd rather live, unless they've committed some sort of offense against the tribe. Right? That's kind of universal. And if you disagree with the ethics of your society, which they have written into law, and act on that disagreement, there are consequences. You go to jail or other places. Our colleges are writing professional codes and standards on either the consensus of ethics or what those in charge of those colleges believe the consensus ought to be, which is also kind of how law works. It's either the societal consensus or it's the consensus of those who have the power to make the laws. In a well-functioning democracy, it tends to be the former. And of course, in a totalitarian state, it's the latter. So our colleges are also writing professional codes and standards based on how they think we ought to behave. And we're all making... The other thing that is happening that you will encounter is even ethicists can't come up with solutions to questions that have not yet been posed. And so what they come up with instead is decision-making processes. So there will be questions that are raised by the next infectious disease epidemic in Canada that haven't been thought through yet, but there are really good processes that you can follow at 3 o'clock in the morning to work through those things, because it's kind of hard to get an urgent ethics consult at 3 o'clock in the morning. So all of those things flow out of ethics. Well, where does worldview come from then? Oh, sorry, let me go. Swipe the wrong way. Historically, through most of human history, and actually in most of the planet still, worldview flows out of religion, sacred texts, theology, spirituality. There are texts, there are beliefs, there are people that interpret that and give that to the society, and that gets absorbed as a child. That is all sort of absorbed into you. In a really complicated way, you've got a mixing culture and social norms and how you're educated and what you're taught. All of that also feeds into what your worldview is. And then your experiences start to change things. So when you were 3, red and shiny may have been in the category of good things, right? And then you touched the stove, right? And then red and shiny was in the category of bad things. And certainly our experiences shape our worldview. Once you hit probably early adolescence, experience tends to be the only thing that shapes your worldview, because all the rest of it's already been absorbed. You'll have trouble at most universities finding the theology or religion department They often still exist at most universities. They're very small departments. Increasingly you have trouble finding the philosophy department too, because as the world has drifted to science, technology, and everything procedural, there's not a lot of people studying philosophy anymore. But the philosophy department is usually fairly easy to find, and certainly in modern Canadian society, an awful lot of thought about the big questions is being done by those in the philosophy department rather than those in the ever smaller theology or religious studies departments. And then things start to interact, right? Because your experience drives your behavior creates experiences feed back to worldview, it drives ethics, and all this gets very complicated. And most medical students don't really like this diagram at this stage because for them, ethics was always very easy. Autonomy, beneficence, non-maleficence, and something else. The joke being that, of course, surgeons, there's too many principles because surgeons can't keep more than 3 things in their brain. And whenever I'm talking to a surgical crowd, generally they'll go, what are the 4 principles? And they'll go autonomy, beneficence, non-maleficence, and something else. The something else being justice. All right. So the central issue is that you've got a certain view of how things ought to be and how the world ought to function and the decisions you ought to make, and you will encounter patients and peers and administrators who have a different understanding of how the universe ought to function and how we ought to behave. And certainly if you're a member, if your worldview is out of step with the culturally dominant worldview, you'll probably be very aware of your worldview and why you think the way you do. But if you're not, if your worldview is pretty consistent with the dominant cultural worldview, you will never, this is just normal, right? Why do you think this about the universe? Well, doesn't everybody? Isn't that just normal? I know there's some people that dress funny and eat funny things and they think differently, but eventually they'll get around to knowing the truth about the universe. So what happens when a patient wants something that you will not provide? Patient says, I want this thing, and you say you need to say no. Where you go with that depends very much on why you're disagreeing, which we're going to explore. But we've been sitting for a few minutes. What are some things that you can think of that you maybe already are aware of that patients will ask for that doctors may say no? CT or MRI. CT, MRI. I want an MRI for my low back pain. Yep, excellent example.
Antibiotics.
Antibiotics for my sore throat, yes.
Long-term narcotics for my back pain.
Opioids, yes. Opioids. Other things? They're always fairly early then. So this is the list I came up with. Oh, where's the other side? Well, apparently the other side didn't make it. All right. So termination of pregnancy, continuing life support when the doctor thinks that is futile, contraception, prenatal genetic testing, CPR. On the other side of the list, plastics, a whole lot of plastics is controversial. C-section just because I want a C-section. Induction of labor just because I want an induction of labor. Antibiotics. There's quite a long list that we can all construct, actually, that you all encounter where a patient wants something that you need to say no to. So how is that handled? I think there's 3 big concepts that you need to keep in your brain when you get involved in these discussions, either with a patient or with a colleague or with an administrator. Fiduciary duty, which is the big word there, patient access, and moral distress. So I want to unpackage these 3 things. So fiduciary duty is the concept that because there is a power imbalance in the relationship between us and our patients or clients, depending on what stream of medicine you're in, we have a duty to do what is in the patient's best interest, even if that's not in our best interest, because of this imbalance. So when you go buy a used car, it is understood that the used car salesman is trying to act in his or her best interest, is trying to get as much money as possible for the car that you are looking at. And it is also understood that you as the customer are trying to acquire that car for as little as possible, and that your interests are in conflict. And that's okay. And there are rules. You can't lie to each other, right? But short of that, short of being dishonest, both parties are permitted to play the game aggressively in pursuit of their own best interest. And that's how it is when tradespeople or salespeople interact with someone providing a service or a product. In Canadian law, fiduciary duty contrasts that. So in professions or vocations where there is a significant power imbalance, Canadian law says it's not buyer beware, but fiduciary duty. So this applies to doctors, nurses, midwives. It also applies to teachers and lawyers and clergy and anyone else who is in a serving profession where there's a power imbalance. And the patient asked me to, or the client was confused, but I wasn't dishonest, is not a defense. Right? And we all like that when we go visit the lawyer, or we go get counseling, or we're in front of the professor. Right? We would all endorse that this is a really good idea. There is also an idea in the Canadian healthcare system that patients ought to be able to access any given service equally well, no matter where they live, no matter all of the things that are enumerated in human rights codes, that patient access ought to be equal and equitable as much as possible, and that what you get sort of by random allocation, and you walk into a merge, the fact that you're rich or you're poor, the fact that you live in downtown Toronto or you live in Fergus, rural Fergus, where I live, should not change access. Patient access is very important to all of us in terms of how we conceive of how healthcare ought to work in Canada. And this is also a really important duty. The other idea is moral distress. So if you, as somebody who works in the healthcare system, are forced to behave in a manner that is not consistent with your ethics, with your worldview, and you might be forced that way just by circumstances. You may be encountering pain and suffering that you can't ameliorate, and inside of you, you say, this is not how it should be. You're experiencing moral distress. So moral distress, a certain amount of moral distress is unavoidable in the work that we do, but certainly we would not want to create a system that creates more moral distress than is necessary, because that destroys people in the system, and they burn out, or they get addictions, or they jump off of bridges. And so we need to design a system where moral distress is minimized, but also where the effects of moral distress are mitigated. And there's an entire industry now around physician well-being and mental health, because people are recognizing that this is a huge problem. So those are three very big concepts to keep in mind when you're engaged in discussion. So what if the patient wants something that you would love to provide, but you can't, right? So I work in rural Canada. There are all sorts of things that you just can't get in rural Canada because there's not enough patients around for us to afford to provide that. And so this is a really easy one. We all agree that what you need to do is transfer the patient. Right? I can't go into a merge, somebody consults me for right lower quadrant pain, and I come down and say, well, it's not your ovary, your appendix looks like it's about to explode. I don't know how to do appendectomies. Good luck with that, and walk away. Right? We would all agree that that is not on. That's not what we want. So if I think my fiduciary duty and the fiduciary duty of the system is that you have an appendectomy, but I lack the skills to provide an appendectomy, I must refer. That is my obligation. That's how I fulfill my fiduciary duty. And this is, of course, Orange Ambulance, which occasionally visits our community. So if you have a multi-system trauma, we can't manage that in Fergus. So as soon as possible, we'll get you out of our trauma bay into one of these helicopters and off to a place where they can manage that. And this is a pretty easy one. It gets a little more complicated when you find yourself saying no, when the professional consensus is that you should say no, but that brings you into conflict with the patient, right? And the classic example is the patient says, I want antibiotics because I have a sore throat. And there is a professional consensus that fiduciary duty dictates that you not provide antibiotics for a viral upper respiratory tract illness. And if you disagree with that and choose to provide the antibiotics, the patient will be happy. But if the college or your hospital administrators find out about that, there will be some consequence to that. And there is a whole skill set that hopefully you acquire through professional competencies or clinical training around how you have that conversation. To say, well, actually, the antibiotic, this is viral, the antibiotic is not helpful, the antibiotic will be harmful, this is going to damage you, I can't, in good conscience, cause you damage. Here, I would recommend some throat lozenges, so they still go home with something, they came to get something, they still go home with something. And also entire public relations campaigns that the government and the medical societies are doing to try to make those situations happen less often. So this is an ad, I think, from somewhere in Europe, right? Cold or flu, right? And we've got big choose wisely signs in all of our offices now because we're trying to educate the public so that we have these conversations less times, right? And so what you ought to do is easy. Doing it is the art of medicine. And the art of mitigating that. And it takes a great deal of time and energy, and that's just our job. It works against our best interest. It'd be my best interest just to write the script. Patient's happy, more likely to come see my emerge when they get the next sore throat, right? It'd be my best interest to write the script, not in the patient's best interest. Fiduciary duty says no. So what if physicians differ on what fiduciary duty dictates, right? So what if you think what's in best interest is that fracture get casted a certain way, and another chunk of the profession thinks it should be casted in a different way, right? What if you polled 10 colleagues, you get 3 different answers? Where do we go then? What does the law, what do regulations say? How do you proceed? Some things are clear that in that situation, you need to remain a caring professional, that you need to continue to put the patient's best interest first. You need to be willing to take the time to gently and carefully and in a culturally appropriate way, relevant to the patient, explain why, yes, I know some of my colleagues would be willing to do it this way, but I'm not willing to do it this way. And caring, and even if you choose to go and get this done that way, I am still your physician. You haven't offended or hurt me in any way. This doesn't affect your care in any manner. For the rest of things, and then to fully explain why some doctors would say yes when you're going to say no, and this is even perhaps more important when you're going to say yes, but some of your colleagues would say no, because the patient may eventually discover actually that your approach is not what some physician is blogging about. So yes, you would like me to approach it this way, and I think that's consistent with what I need to do. I think it's important you know that a chunk of our profession disagrees, and I agree, and this is why I agree, this is why they disagree. And hopefully, if the system's functioning well, in all of these areas, somebody's doing some kind of study to settle the dispute. And actually, if nobody's doing a study and we're still arguing about it, it's probably because the studies don't direct any one direction, and then that's the thing I find doctors argue about the most. So if you are in a room full of doctors and their anesthetists argue endlessly about normal saline versus Ringer's lactate. Why? Because it doesn't make any difference. So there's room to argue on really fine points of some obscure study. Whereas if you say to anesthetists, what's the right way to intubate a patient, they'll all give you exactly the same answer because there's good literature. So when doctors are arguing, it's generally because there's no literature, but often it's because the literature actually settled that it doesn't make a difference. But every doctor somehow feels the need to choose an option and defend it to the point of death. And no abandonment, right? You're choosing to go see colleague X to have it done this way. I am still your physician as long as you want me to be your physician. I'm not going to abandon you. So this is everyone agrees to this, right? There's no dispute about this. And in many jurisdictions, this is as far as you have to go. You can stop there, and then the patient can go seek that thing that you're saying no to from someone else of their own volition. Some jurisdictions are starting to explore whether maybe the standard needs to be a little higher than this, right? And of course, the jurisdiction that most people are aware of is the CPSO, the jurisdiction that we're currently in, which in 2015 said, well, actually, we think you need to go one step further. And if you're choosing to say no on some sort of moral grounds, on some sort of ethical grounds, then you have an obligation as part of your fiduciary duty to, in an emergency, actually just say yes. And in real life, that never happens. I have yet to encounter a morally controversial procedure which would actually need to be provided in an emergency. I have certainly encountered philosophers who have constructed bizarre and unlinked to reality scenarios where such a thing might happen. But I have never actually encountered anyone involved in clinical practice who has been able to relate to me such a scenario. But of course, the colleges feel the need to cover every possible scenario, even if it's only going to occur to one doctor in Canada every 100 years. So I would love if anyone can come up with that sort of scenario. I'm still hunting for such a scenario. Most of the time, it's not an emergency. And what they require is that you then make an effective referral to someone you know who will say yes. That is contentious. As was talked about previously this weekend, there are currently lawsuits about that sort of standard, and I'm very interested in seeing how that will turn out. So you may find yourself a bit of an odd doc. You may find that in most scenarios, when you are saying no, all of your colleagues would say yes. You are out of step. And that can be a very uncomfortable place to be, a very challenging place to be, a very worrisome place to be. So I want to give you a few thoughts on best practices if you're the odd doc, which was the original title of the talk. So you will occasionally find yourself saying no to patients, aware that most of your colleagues would say yes. And there's some best practice there. So one of them is that you communicate that you are different very early, and you communicate it as often as it may be relevant. So in the context of family practice, if you don't prescribe opioids, right? You just don't. You just don't prescribe opioids. Or you don't prescribe contraception, or those sorts of things, then it should be part of your new patient information orientation pamphlet. We charge $10 for sick notes. The phones are answered from 9 to 3, Monday, Tuesday, and Friday. And right, you've all got that package, and you've all phoned a doctor's office, or at least if you're a consultant, you've gone looking for an ultrasound report and phoned a doctor's office on Wednesday afternoon to learn that they don't answer the phones on Wednesday afternoon, or Friday afternoon. Friday afternoon is even worse than Wednesday afternoon now. It's just part of that orientation to the practice. And then a patient, if they're not comfortable paying $10 for sick notes, or really needs that ongoing opioid prescription for their low back pain, or is uncomfortable with the fact that you won't prescribe contraception, is then free to find another physician who will provide them with the care that they believe that they need. And then whenever you are aware that a patient's encounter may be headed towards something that you don't prescribe or don't do, to come back to and say, well, I think at the end of this, you're going to be looking for an opioid prescription, or you're seeking emergency contraception. I want to let you know right now that I don't prescribe that, or I don't provide that, because I don't want to waste your time, right? I don't want you to disclose a bunch of potentially sensitive details about yourself, and at the end of it, not procure the service that you're seeking to procure. And in that conversation, all of your compassion needs to be front and center. Because I have yet to encounter somebody who says, I don't do X even though I think it's consistent with my fiduciary duty that I provide X. I've not encountered that. So your choice to say no is flowing out of your wanting what's best for the patient. And if you communicate that well, what should come through is your compassion and desire to do what is in the best interest of the patient. That should be coming through. And again, if you've got a scenario where you're saying no to something you think is actually in the patient's best interest, I would love to hear that. But I have never actually encountered that as I've explored this. And you need to make it very clear that I'm going to continue to care for you and be your physician, even if you're choosing to go and procure the service from somewhere else. I'm not abandoning you. Your choice here doesn't change that I am going to continue to be your doctor and work in your best interest. Now, there are some limits to that, right? If a patient decides they're going to get all of their prescriptions from somebody else, how useful is it for you to continue as their primary care provider, right? And you must say, well, actually, I think it's probably better for you that if that doctor is going to provide you with all of your opioid prescriptions, that they actually be your primary care provider. As a consultant, often I'm coming across things inadvertently. So you came in for your abnormal pap smear, but now but then you bring up the fact that you also have low back pain, and could I just prescribe, give you a script for that? I'm going to say no, but my saying no doesn't change the fact that I'm going to still take care of your abnormal pap smear, right? And that needs to be. I'm not abandoning you, and be honest about the fact that you're going. This is all sort of disclosing honestly to the patient. I'm not going to provide this because I don't think it's in your best interest for the following reasons, or it's not in your best interest that you get an opioid prescription for your low back pain from a gynecologist. It's out of my skill set. It's not in your best interest that I practice this out of my skill set. And it ultimately comes back to how if you were a patient, right, and a physician, and you felt that you really needed something, and your physician was going to say no, how would you want to be treated? I would want to know really early. I'd want to know it posted, so I didn't sit in the waiting room for 2 hours and then not get that thing. I would want them to communicate that. I would want them to continue to care for me even though I go somewhere else to get that thing. All right? This is all how we would want to be treated. So if you're doing patient-centered care, this kind of makes sense. The other group that you'll find yourself saying no to are administrators. How to say no to an administrator? You find it's pretty much the same list, right? Communicate early and often. So when you're applying for privileges to practice emerge, and in that emerge there's not a sign about opioids, but you're not comfortable prescribing opioids in an emerge setting, you probably should communicate that to whoever's interviewing for that emerge job. And whenever it comes up that there's some change in policy and procedure in the hospital, you need to circle back and say, well, actually, I'm not going to be comfortable with that. Be compassionate. I'm amazed how many people are so good at being compassionate to patients. The way they treat administrators, man, you're a different person when we put you in a boardroom. We're all people trying to do what's in the best interest of the patients in the building or the patients in the clinic. And we're all a mix of good and bad intentions, and we're all a mix of things we're good at and things we're not good at. There's no other group in the system that has a monopoly on bad intentions and evil outcomes, despite what you may hear in the doctor's lounge. So be kind and compassionate in the boardroom. Do other work, right? So probably there are other things that nobody else likes doing that is difficult, that you're perfectly comfortable doing, that you can volunteer to do, right? So if you don't, so in the context of in the obstetrics and gynecology world, certainly providing terminations is an unpleasant task that only a few people do, but I can come up with another long list of very unpleasant tasks that nobody wants to do. And it is very hard for someone to accuse you of making choices based on being self-centered and pursuing what's in your best interest, if everybody knows you're the person that volunteered to be chair of that committee that nobody's ever wanted to be chair of, or you're the person that picked up the morning shift that nobody likes, or you're the person that runs the walking clinic on Saturday evenings, or you're the person, right? Because people, when you say no to administrators, a couple things get thrown back at you. One is, well, everybody has to participate in the stuff, in the unpleasant stuff, right? And that's kind of selfish. And those things don't work if the administrator knows that that's not you. And then treat the administrator the way you'd want to be treated. Pretty simple, right? All of you will find yourself supervising others, probably, and needing to assign unpleasant tasks to people in that group. And how would you want that to go? When you sit down with your office nurse and say, somebody needs to do X, Y, or Z, you'll all find yourself being administrators in one form or another.